I've adopted those slides from Dr. Snehal Bhatt, who used to run a lot of these echoes, and has gone back and doing some more clinical work. So I just wanted to acknowledge him. A lot of the talk is going to focus on how to initiate somebody with buprenorphine. When we talk about, and I think an area of a lot of confusion is this low dose versus traditional dosing versus what the package insert says, and really want to kind of focus on a lot of that today, the different formulations, the different options, essentially, that we have here. As far as disclosures go, is in most of my talks, and I think I disclose this, I tend to use the term Suboxone or Subutex just because I think it's clearer to the audience to say the trade names as opposed to buprenorphine with or buprenorphine without naloxone, just to be a little bit easier to facilitate. Also having two injectable products that are a little bit different, to be able to kind of appreciate some of those the differences, I think, with the trade names kind of communicates. With that, as always, when using trade names, if you guys feel that I've got any bias or something, please let me know. I don't have any financial stake in either company.
So one of the questions that we get is, should I start this person on a film or a tablet? To me, this is completely driven by a third party. I haven't figured out which insurance will carry what. And I have some insurances that'll cover the film, but not the tablets, and vice versa. So my role is whatever the insurance company will pay for is what's right for. Both of them are dissolving. Both of them are sublingual. Both of them should be individually wrapped if possible, supposedly to cut down on diversion. But I don't know. I think if I was diverting like one or three of these, which tend to be the most common, like being individually wrapped, sounds more convenient. As far as other options goes, we have the injectable versus self-administered as well. To me, the injectable products I favor in people who I have concerns for diversion, in people that I have concerns with compliance. I prefer it in my unstable housing population, simply because, like, I just don't want them they have something of street value on them. I don't want them to be beat up or robbed. I also favor the injectable products in my youth. Over the years too, we see what like Sergio and Dr. Jacobson think, but I actually, when I'm able to, which is rare, to initiate care on injectable buprenorphine, I think that's a lot easier than doing with the film or the sublingual tablets. There is a new study that came out over last summer, looking at starting buprenorphine in an emergency department, of giving sublingual strips versus a week-long injectable, which is now FDA approved as Brixadi, funded by NIH, and the injectable had better initiation of compliance from the emergency environment from it. But the big advantage of the tablets or the sublingual is really going to be the low cost to it, and I think that's why a lot of insurers prefer it. The other advantage is that it can be dispensed by any pharmacy, whereas the injectable products need to go through the FDA REMS process. So, in other words, your well-known pharmacies, Walmart, Walgreens, CVS, Albertsons, Smiths, generally do not have the REMS availability with it. So I just kind of set that there as some other things that we may be weighing in a little bit as we do. So this next series of slides is going to be a reminder, and I know a lot of you know how to do this, is what the package insert says. So 10 years ago, this is the way we induced the vast majority of people on it, but and then we'll start moving to a low dose after this. So basically, day one is, or what our goal is, we want to wait to get the cow score somewhere between 8 or greater, 8 to 10, 8 to 12, depending on the source that you look at. I would also, this is a point, working in the emergency department, working on the inpatient unit. This was really eye-opening when I moved over to and spent time working walk-in at ASAP. Simply because ASAP, or the addiction clinic, consistently scores patients much higher for their COW score, for their CWIS score, than we do at an inpatient hospital. There are other people have actually done a better job of documenting the scores are a little bit higher. So I tend to, hospital-based numbers, I pretty much push at 8. If they're going to be outpatient numbers, or somebody kind of, home health who isn't maybe as savvy at this, but going to be with the patient, it just knows that I might push that up a little bit on 10. And I think that kind of represents why some of that occurs. There is a subjective opioid withdrawal scale of a SOUS score. And I don't know, growing up in an agricultural community, I can't think of two more inappropriate or rough named for our patients. We're going to give you a cow score, which is always a female cattle, or and a sow is a female pig. So we're not calling our patients female pigs or giving them a female pig score name, but just the trivial pursuit of the world we live in. But the SOW score is a subjective score, and this is something that's worth sending a patient home on, so they can kind of get to the point. In practicality, what I've done personally, and again, if you guys have other tips or tricks that you do, I think sometimes sharing those anecdotal stories are helpful. Please feel free to put those in the chat. Is I tell my patients, hey, when you're ready to cry uncle and you're ready to call your drug dealer and you just can't take it anymore, try a low dose. The package insert says start at 4. Meeting expectations of my patients, like who takes one acetaminophen for a headache or one ibuprofen for a headache? Like nobody. They're going to take 2. So who's going to cut a strip in half, or a 4 milligram strip? I guess they come in 2 milligram strips. I'm sorry. That I just want to try that 2 milligrams, see if you feel a little bit better. What I'm really trying to do hard here is prevent buprenorphine precipitated withdrawal that starts early. I think we've all had people that we've initiated with buprenorphine where they've started a withdrawal process, or a precipitated withdrawal, or they're closed off or closed minded to buprenorphine because of it. So again, I want to try to have them to have a pleasant transition, a pleasant reaction to this. And then they can repeat the dose. I tell them, repeat it in 2 hours with the hope that they wait an hour, or even a half hour. In the ER, as I'm going through, like I reassess in 15 minutes to 30 minutes after they received it, just to be on top of it. Again, the kinetics, or how rapidly the absorption occurs. This is just an example of the cow score, or I'm sorry, the sow score. And again, this is highly subjective, because how anxious am I feeling in withdrawal? It means that, I get up to numbers pretty quickly. On day 2, basically is they're going to come in, they're going to feel pretty miserable. Once they start getting those higher scores, that's the time when we start doing the induction. And the package insert says that we go up to 12 milligrams on the first day, and really essentially by 16 milligrams on the second day. If you've heard heard me talking in the fentanyl era, which all these slides, which the package insert clearly was in, is 16 milligrams no longer hold people more. But essentially what the FDA is trying to get to happen, what I'm trying to get to happen, is that we get a patient up to therapeutic drug concentration fairly quickly, because what we don't want them to do is to get frustrated with feeling miserable and going back and using. And then day 3 is going to be kind of on an inpatient stay, is kind of that if they're not already up to 16, or we need to go above that, we're going to be getting the titration. I know Eric, I know Sergio and I have talked about this. All 3 of us, we kind of really in today's era are getting people on 20 to 24 milligrams by, if not the first day, the second or third day for sure. How long to wait for induction? Again, number one principle in medicine is treat the patient, don't treat numbers. And so how is the patient doing? How is the patient feeling? What are their prior experiences with experiencing withdrawal? As far as short-acting opioids, a rule of thumb laid out by the package inserts 12 hours, long-acting or longer-acting 24 hours. Methadone is really going to be closer to 2 days to start having withdrawal effects. Now, understand this isn't necessarily the peak of withdrawal. This is more on kind of when we're starting to see some significant withdrawal effects. If we're transitioning somebody off of methadone, this may, I think, most commonly be done in an OTP clinic. But as we have patients who may show up in the hospital service, and starting up the segue for the next part of this talk, I think this makes sense. So the whole concept of low dose induction of buprenorphine was really developed by a Swiss physician, and to transition off of methadone for pain and onto buprenorphine. And really historically what we've done is we've tried to titrate them down with methadone to get them under 40 milligrams. For those of you not familiar with methadone dosing, 80 milligrams or above is usually where most of my patients are targeted. So they're on much lower doses. Once we start titrating down, that also increases their risk of not only withdrawal, but increased stress on them. So doing this acutely may not be the best thing to go. And then once we get them down to less than 40 milligrams, we start weaning them off or stop it for 48 hours, really allow for that withdrawal to kick in. And the withdrawal is usually a lot longer given the long acting opioid. We'll manage it with the old kick kit of clonidine, ibuprofen, loperamide, trazodone, hydroxyzine. I usually kind of prioritize what we're going to put on board based on what the patient tells me it bothers them the most in opioid withdrawal, and then essentially titrating up and going with that. And trying to avoid precipitated withdrawal and having that discussion that this is something likely going to happen ahead of time. Because again, managing expectations ahead of time generally goes better with our patients. With this, patients, as you would imagine or have experienced, oftentimes struggle with getting a COW score high enough. And because we have a case, I want to start moving through some of these slides a little bit faster. I think when Snehal started teaching this, the low dose induction was kind of the new or the emerging way to go. And these slides, I feel like I can go a little bit faster through in 2025 than I would have a few years ago, just because in most of our sessions, this is the way that I think most of us are leaning. And the low dose idea is that what we bind to that opioid receptor, and buprenorphine is a partial agonist and is going to displace some of the fentanyl, the heroin from the methadone from that, and can precipitate out withdrawal. However, if we start at a really low dose of this and we go up slowly over the course of a week, we generally can avoid some of the withdrawal phenomenons. This is the one that Dr. Bott had chosen to put in here. Understand that I took the other slides out. There are more than a dozen different descriptions of a low-dose induction in the peer-reviewed literature. And I haven't done the systematic or the meta-analysis of these myself. It's on my list of things to do. But all of them appear to work. And I think the point is, it's like smoking meat or aging wine. Go slow, go easy, and the patients generally do well. The challenge, I think, on the inpatient side, and even on the outpatient side, is really how do we get down to a 1/4 milligram? Because we have we have 2 milligram strips, we can cut it into a fourth and get down to a 1/2 milligram. pharmacy standards would say is we could cut a pill in half, but really a fourth shouldn't be done. So that's at UNM, we can't do it in a fourth, so we use pain doses of medication, of buprenorphine that are lower. But this is honestly what I tell my patients to start with a 0.5 milligram. Collectively, if you've had experience with withdrawal, please put it in the chat. I haven't had any withdrawal. I know Sergio and I have talked about it. Vanessa, we don't touch base nearly enough as we should. And so I don't feel comfortable speaking for you here, but if you've had withdrawal, let me know. But I have not, and I know Sergio has not. Seeing Vanessa shake her head, I think that answers the question. So thank you, Vanessa. I appreciate your feedback. But then if you double the dose every day, by day 6, they're at 16 milligrams as well. And then do a maintenance dosing, and how long and how much. I'm going to make this kind of my last slide just so that we have enough time for the case. So the FDA approves up to 32 milligrams for dosing. There aren't a lot of studies at a higher dose. I would be curious personally if 42 milligrams would be superior to 32 milligrams, or I'm sorry, 40 milligrams with an extra 8 milligram. But at some point, what's pharmacology wise, we're going to hit that plateau of and we kind of get a maximum effect where it's probably not going to be more effective. There is an NIH-funded clinical trial that UNM was part of, that in the next, I would say, next year or 3, we should have results comparing 16 to 32 milligrams in a randomized control multi-center study. And the preliminary results looked like it favored the 32 milligrams over 16 pretty strongly. But we shall see. Most insurance companies will cover up to 24 milligrams and require a prior authorization, usually for more than 24 milligrams. For those of you seeing more, writing more of these than I am currently, please let me know in the chat. But I haven't historically had problems writing getting the prior authorization if a patient had continued use at 24 milligrams or a documented a relapse or something, that if we needed to go higher and they were still having the cravings, hasn't been like a big barrier. Just kind of becomes a checkpoint. With that, let me open it to any questions that you guys may have.